Autism spectrum disorder necessitates a tailored approach to care, recognizing each individual's unique strengths and challenges. Early intervention can significantly improve outcomes, insights, and advances in care for autism. Tonight, On Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. I'm Dr. Debra Johnston, your volunteer Prairie Doc for this evening's program, and tonight we are discussing autism and answering your questions throughout the show. Autism, or autism spectrum disorder, is a complex neurodevelopmental condition that affects communication, behavior, social interactions. People with autism may experience a wide range of symptoms and challenges and may display unique strengths and abilities as well. Early diagnosis and intervention can significantly improve outcomes, helping individuals develop essential skills for daily living and set them up for success academically and socially. Awareness and understanding of autism are important steps we can take to support that goal. In the studio this evening are Dr. David Ermer from Avera Medical Group Behavioral Health and Dr. Carrie Kippes from Sanford Children's Specialty Clinic. Kippes, sorry. Thank you both for being here with us this evening. Dr. Kippes.
Yes, thank you.
I'll try to get that right. It'll probably just be Carrie, though.
That works.
That'll be easier for me. My maiden name was Rodigero, so I have no room to not pronounce other people's names correctly. Tell us a little bit about your background and what drew you to your field.
So I'm a developmental behavioral pediatrician, which means what I'll tell families is I'm a general pediatrician, and then I did extra training in child development and behavior. Work with kids with a wide range of developmental differences or difficulties with learning, and sometimes we help with medication management too.
Fabulous. Dr. Ermer, same question. What brought you to child psychiatry?
Well, I really enjoyed working with kids, and I really enjoyed psychiatry, and I felt there was something, you know, working with kids may be preventive, and maybe if you see kids early enough, you can kind of change their trajectory. So that really drew me, and I just, love working with families.
And working with kids is all about working with families. The
Absolutely.
Families are so important in determining that child's opportunities.
Absolutely.
Yeah. So before we get started, I just want to pause and express my gratitude to all of our viewers. Your support is immensely valuable every week. Each dollar you contribute goes a long ways in helping us create meaningful content that guides individuals in making informed health decisions. Now, let's turn our focus to you, our audience. We invite you to submit your questions for tonight's conversation on autism. There are 3 ways to reach us. Call us at 1-888-376-6225. Send an email to ask@prairiedoc.org or engage with us on our Prairie Doc Facebook page. We'll do our best to address as many of your questions as time allows. If we can't get to yours, we sincerely apologize. All of your questions are anonymous and no information will be saved. However, if you would like to leave your name, email, or phone number, you'll be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. That is not a requirement to submit a question. We'll announce the winner at the end of the program. So, guys, there were a couple things I wanted to kind of start the conversation with so that everybody kind of had some baseline understanding of what we were talking about. I think a lot of people have this vision of what autism is, or maybe they just kind of don't really have a good understanding of what autism is. So let's just kind of start there. What are some of the symptoms we might see with autism? Dr. Ermer.
Well, yeah, there's a group of symptoms, and I think you had said it best earlier. When you've seen one person with autism, you've probably seen one person with autism. You just can't assume you know that person. They all come with their unique characteristics, unique strengths and weaknesses. But the two big areas are social skills deficits and then repetitive or stereotype behaviors or interests. The social skills deficits can range anywhere from really difficulty reading social cues. There's a term called the theory of mind, which means you have trouble putting yourself in somebody else's shoes. I think there's a joke like with autism, someone's on two sides of the river, like one person yells, "How do I get to the other side of the river?" The person with autism yells, "You are on the other side of the river." But that's that inability to put yourself in that person's shoes, so those social skills deficits. And again, they can range from just struggling, they want to fit in trouble, to just some people just, in severe cases, don't even interact with other people.
Or can't communicate at all, exactly, or nonverbal, and other people just can't read the room.
Yes.
Yes. And then the other aspect of that, the repetitive, stereotypical, what might that look like?
That some people think of like classic hand flapping or toe walking, and some of those repetitive physical behaviors, but it can be language, being repetitive with language, or atypical aspects of language. You can see behavioral rigidity that parents will a lot of times describe like kind of a my way or the highway approach to everyday life. They struggle with schedule changes, transitions, and a lot of times we see sensory difficulties, whether we're sensitive to sounds and touch, or we seek out a lot of sensory input with a lot of jumping, spinning, crashing our body, those kinds of things.
One of the things that we always think about in primary care is the kid that lines up their toys. And they always line up and count their toys in the same order, but they don't play with the car. They line the car up, so they have that unusual habit of interacting with that. Are there other things that might look like autism spectrum disorder?
Oh, absolutely. There's a myriad of things, even just in intellectual disability where you struggle with communication. One of the most noticeable signs of early autism is language. Parents notice speech and language, and the most common cause would be hearing impairment more than autism. And certainly we see kids with social anxiety. They may not interact well socially, but it has nothing to do with autism. It's just they have a great high stress level when they get in social situations. So there's a number of psychiatric diagnoses that can certainly mimic autism. Even some kids with ADHD, they don't take the time to pay attention to social cues. They're just going, and so sometimes they can look like they have autistic features also.
All right. Are there disorders that might go along with autism?
Yeah, we often can see, obviously there's communication delays and difficulties that are part of the diagnosis. We can see ADHD is really common, sleep difficulties are really common. You can definitely see anxiety symptoms that can impact behavior, and just struggling with emotional regulation, feeling frustrated, and instead of it being a small amount of frustration, it's kind of this volcano of emotions that happens.
So the bottom line is that autism is kind of a descriptor for people who have challenges in a couple of more specific areas. So why does it seem like we're seeing more, hearing more about autism these days? Dr. Ermer?
Well, I know that there's a lot, they talk about the epidemic, but I think going back to the early days where it was diagnosed in, I mentioned earlier, Leo Connor diagnosed it in affluent white boys. They didn't look at girls and other races. I think we've broadened the criteria with the new diagnostic criteria, but we're also recognizing it more in girls now than we used to. And I think we're just recognizing it in a lot of individuals that we weren't looking
before. Does it present differently in these different groups?
It can. You can see some differences, specifically like boys versus girls. Sometimes girls can have a little bit better eye contact maybe than their male counterparts. So that sometimes can make it harder to pick up on that diagnosis earlier. I think a lot of times I'll tell families that it's hard if our kids are that their intellectual ability is within that average range, and sometimes you don't pick up on some of those social difficulties until they're a lot older. And so some of those milder cases or those of kids we don't pick up until they're well into school age.
Or even adults.
Or adults,
I mean,
yep.
how many people have we heard from who have announced that they were diagnosed as adults with that higher functioning autism, or what we used to call Asperger's syndrome, so that can really fly under the radar. So, and then kind of the big question that I think is on everybody's mind right now: what causes autism? We were talking, when we were talking to the students before, about the refrigerator mom theory.
Yes.
Yeah.
That was the start. They thought it was cold, aloof moms, and that has been debunked a long time ago. I think the current feeling is there's not one singular cause. It's a very complex interaction between genes and environment. And I have to take a step back. Autism should be called autisms. We lumped a bunch of traits together and called it autism. We know that there's a lot of different pathways. There's not one clear biologic pathway. So we're dealing with a lot of different things that can cause somebody to have autistic characteristics. So we're never going to find that singular cause. It's a complicated picture between environment and genetics. I'm going to say that vaccines don't cause autism. There's been plenty of it's been overstudied, and there's just no connection between the two. So we know that, and I think we're probably misguided if we're looking for a singular cause. It's complicated. We even know that there's about 30%, 15 to 30% of kids have like a spontaneous mutation that may lead to autistic features, but other kids have the same mutation and they don't have autistic features. It's just a really complicated picture.
We went through a period in time when we were like, well, we're going to find the cause for cancer. We're going to find the cure for cancer. And fortunately, we've moved past that in cancer research and cancer treatment and cancer understanding. But we need to move past that in autism treatment too.
True, there is not. I think the one thing that the researchers are uncertain what causes it. It's multifactorial, but they're certain that it's not
one thing.
There's not going to be one or even two things that are causing autism.
Yeah, autisms. Maybe
autisms.
we should start the.
It is autisms. It really is.
Yeah.
There's many pathways there.
And many different constellations. Anything to add to that, Carrie?
Yeah, I think I really try, when having this conversation with families in the clinic, I try to say, this is how your child's beautiful brain was formed early in pregnancy. You had as much control over this as whether or not they were a boy or a girl. And so, we may or may not, if we do any genetic testing, find a difference that might help us explain it, but we might not. But we know that your child has this different learning style, and here's some of the approaches that we're going to do to help try to narrow some of that gap that we're seeing with their development.
I think that's important, that it's nothing that you as the parent did or didn't do that caused this outcome any more than you caused your child's club foot or cleft lip and palate or asthma or Down syndrome. It just is one of those things that happen. It happens. And that's a very, very important thing. So, excellent. So let's get to some questions. That gave people time to send in some questions for us. So here is an email, and this individual says that their grandchild has some social issues. Can his parents take him to the doctor to be screened for autism, and what tools does his doctor use for this? That is some great questions. I'm going to throw that one to you as the pediatrician.
Yeah, great question. I think, the nice thing is with the American Academy of Pediatrics, we have a very prescribed kind of targeted times that we're doing developmental screening and developmental testing. And most pediatric and family medicine practices are using a tool called the MCHAT-R. And it's a screener that looks at some of those symptoms associated with an autism spectrum disorder. And again, it's a screener. It's not a diagnostic tool, but it can identify if there's red flags that would warrant further assessment.
And I think that's one of the really important reasons to go to those well child visits, because that is one of the important things that we do at those visits, is look at that child's development, look for those red flags so that we can find potential problems early and take that step to intervene.
Absolutely.
So even if they're not due for any shots, or even if you're not doing shots, those visits are still really important. So, And here's a question from Facebook, and this is a really good question that we were having a conversation about earlier. How do you differentiate between autism and other developmental differences?
That's a great question. No, I think even in my office where I've worked a lot with autism, if I see autistic characteristics, I refer them on to a multidisciplinary team. I really feel that team approach, you have speech and developmental peds, or even genetics, and then you have OT and all these different fields, and psychology doing testing. I think you want a full team, because sometimes because a diagnosis has a lot of gray areas, I think you want a full team really seeing that child, and we're really getting a lot of information from the parents, obviously, because the parents know that child more than anybody, and especially with younger kids, a lot of our diagnosis, our problems, is delineated by what the parents present. How are they at home?
Yeah, and I think that it goes back to that, you're trying to find the thing that fits best, the description that fits best, but there's not a single test that can say, oh, you've got autism. Like, I can do a test and say you have diabetes, or you have celiac disease, or you have these things. And with autism, and a lot of psychiatry, we just don't have that kind of diagnostic ability. So.
Exactly, and sometimes it just takes maybe more than one visit or several visits to just be able to observe the child, gather that data from school or other environments too, to really figure out, are there truly social deficits there, or is it more we're having a child that's struggling with how they're processing information, or their communication delays, or what are creating this presentation that are making people concerned about an autism spectrum disorder.
And we actually have a wonderful roll-in that will explain this in a little bit more detail. The autism diagnostic process does not have a one-size-fits-all approach. Prairie Doc spoke to a licensed clinical psychologist about how individualized evaluations are key to understanding and supporting each person's unique needs.
Amy Delaramich is a licensed clinical psychologist at the University of South Dakota's Center for Disabilities, and she explains how parents and caregivers are an important part of the diagnostic process.
We really want to make sure that we are hearing, what does the child look like in their home environment? What do they look like in the community? And so the people that know those children and know that best are those that spend the most time with them, and that's your parents and your caregivers. So we really bring our parents and caregivers into the diagnostic process through having them complete rating forms, having interviews with them, having them be part of that evaluation.
She says how the patient communicates is vital to the process.
For the diagnosis of autism, we really want to look at communication. How is that child communicating? We want to look at their cognitive and intellectual level. And so what are they learning? How are they learning? How are they retaining that information? We want to see how are they kind of responding to their environment from their sensory perspectives? How is their gross and fine motor skills? So you can see that there's a lot of different disciplines that would be involved in that.
Knowing what typical development looks like is important when determining whether your child might be showing early signs of autism and deciding if a developmental screening or evaluation is needed.
But the bottom line is that if any parent, any guardian, any grandparent, any caregiver, if they're having concerns about their child, spending some time talking with their pediatrician or their family medicine provider would be something we would really recommend, because again, early intervention is going to be the best predictor of future outcomes. And so the earlier we can get in and start maybe providing some support, the more likely we are to see some progress in those areas.
I think the bottom line is diagnosing autism is not easy. And it takes a lot of people and sometimes a lot of time and a lot of consideration to make that diagnosis. Why are we seeing people diagnosed as adults? What do you think is driving that, Dr. Ermer? That's probably more in his ballpark.
No, I do. I think people are recognizing, I think it's people struggling. They don't come in looking for a diagnosis if things are going well in their life. They've realized, my relationships aren't going well. I'm struggling at work. and maybe they fell into that category, especially if they're older, where we really weren't looking for higher functioning people with the older criteria, and they've been, or maybe they have a relative that was diagnosed, because we do know it runs in families, and I think they're looking for why they're struggling, and it's a reasonable thing to do.
Yeah, I think that that's important, that those, people in my generation, our generation, we thought of autism as Rain Man. Yes. That was where how we visualized it. So people that didn't have that severe of challenges just didn't rise to our radar.
Right.
So, yeah. We have a question from email. We hear about more kids being diagnosed with autism in the news. Are we seeing more kids having autism, or are doctors just diagnosing it differently than before? This is a great question, and it's just kind of a fundamental question when you're interpreting that information. Carrie?
Yeah, I think we are seeing it. We are seeing more of it, and I think there's multiple reasons for that. Our diagnostic criteria have changed over time so that we're capturing people who have milder symptoms on that continuum or on that spectrum. We also have a lot more awareness of families knowing what to look for. And we've had campaigns from the CDC about first signs, what to watch for. So we are seeing more diagnoses over time with that.
And is that so much an increase in actual people having those issues, or is it an increase in our recognition and our giving people that diagnosis, or both?
I think it's both. I think and I'd love to hear Dr. Ermer's thoughts on this too, but I think we are recognizing it. We're identifying individuals that maybe would not have been identified 10, 20 years ago, but I think we are seeing more of it too.
I would agree. I know the CDC's position is we're recognizing it more, but there's a lot of people who disagree. I think it's kind of unanswerable if you think about it, because it's a good debate to have. I think there's a lot of people feel that there may be an uptick in the number of cases, but absolutely I do know we're recognizing it more for sure.
Absolutely. There's, we can't go back in time 200 years and figure out how many people would have been diagnosed today. I mean, we just can't do that. We don't have that ability.
I did pass a DeLorean today on the road.
Did ya? Oh, well, maybe I misspoke. Maybe I'm wrong. One thing that I learned in the process of kind of doing a little bit of homework for this is one of the factors that influences the rates of autism is the age of the parent.
Especially, I think, there's different theories on that. One is as you age, you have more mutations, and that's one theory. And there's also a social theory, especially with men, that maybe they don't form relationships till later in life. So there could be both answers.
Yeah, so maybe it's not so much causative because of their age, but that causation and correlation that we were talking about, that maybe like, why do people take Tylenol when they're pregnant? Well, they take Tylenol because they're sick. And we know that illnesses and infections can change your rate of your risk for a child with autism. So
yeah, I think that's a good thing to make clear. High fever is a much riskier proposition for autism than Tylenol in pregnancy.
Absolutely.
Yeah. And for a lot of other things,
right.
A lot of other complications in pregnancy. So causation is not necessarily correlation. So that's important to remember. We have an email question. My child has recently been diagnosed with autism, but it is not as evident as others. Our doctor said we needed the diagnosis to have resources. Why is this? Carrie.
That's a great question.
It is. Oh my gosh, that's a big one.
It's how our system works, and so having the appropriate diagnosis is what then allows for, if we're doing outpatient therapies, to be able to have that covered by one's insurance. And so that identification is what allows for those services to be obtained and to be initiated and to be ongoing.
Yeah, and optimally, what might an optimal schedule for therapy look like, Dave?
That's a really good question also. I know that early on for fairly involved kids, I think they're looking at like 20 to 40 hours a week. For more higher functioning individuals or maybe more just directed therapies, sometimes like ABA therapies, maybe 15 hours a week. It depends. Again, it's individualizing the treatment. To you can't just say this is what you need. You have to really take a look at each child's strengths and weaknesses and the family's strengths and weaknesses. Unfortunately, we are governed by what their insurance looks like also, and that's, even though we know certain things can help, sometimes families can't afford it.
20, even just 15 hours a week of therapy would be really expensive to try to pay for out of pocket. And I have a child who had a cleft lip and palate, and just the amount of therapy that he got for speech alone wouldn't have been something we could have done without the school and the insurance, and let alone 15 to 40 hours a week of therapy. That's a lot.
Well, and we're a rural state. There's areas of the state where these would be great, but the resources aren't available, and people can't drive 3 hours to go get those resources. So being a rural state, there's some unique problem solving we have to do to really help these families.
Yeah. Absolutely. Where else might having that label, having that diagnosis be helpful for this individual, Carrie?
Well, I think, again, making sure that we have access to resources. There are programs within the state that families can qualify for with a medical diagnosis. So, for example, Family Support 360, which is a program that can help families possibly qualify for secondary Medicaid to help cover the cost of some of these therapies if there's a limit to what the primary insurance would cover. We use the diagnosis to help track kids that are these individuals that might need services, into adulthood even. And so it's the diagnosis would help us with just kind of tracking individuals that are needing services over time.
And what services they might need, what help they might need as they get older and need to develop different skills than they were needing to develop when they were 3.
Absolutely.
So, are there advantages from an academic standpoint with the school, with having that diagnosis?
Absolutely, because it can help inform learning styles. It also, for better or worse, when a kid's acting out, maybe throwing a fit or not behaving well, I think our fallback is they're being defiant or they're defying our authority. It can help give staff a framework to, hey, maybe this isn't just defiance. Maybe they're upset because they're very rigid in how their day has to go. And as a school, you can say, let's say we had an assembly in the gym today and that's out of the schedule. And that can really throw some kids who are very, routine bound off. And so whose fault is it when the kids act out? We know that, a good intervention would be we start letting the child know on Monday, hey, remember Friday we're not going to follow the schedule, and just present the new schedule. So I think it can help people understand behaviors, but also introduce appropriate accommodations for both learning and behavior.
So anticipating some of those needs and meeting some of those needs so that child can be successful in their
school.
And enjoy school.
We don't want kids not to, we want them to like school.
Yeah, absolutely. So wonderful. So it is important. Don't fight that diagnosis. It can really help your child. Here's a question from Facebook. Could the doctors talk about the process of having a child diagnosed with autism? I think we talked a little bit about this, but maybe we can be a little more detailed about what that might look like. Carrie?
Yeah, for a child coming into our clinic, there would be an initial evaluation to go through the history, what are the concerns that we have, and do some observation, interact with the child, play with the child, do a good physical exam, and rule out any other medical concerns that might be there. Part of that would be having rating scales that family and school might fill out that might help us hone in on the appropriate diagnosis going forward. For some kids, if it's fairly nuanced, we're not sure, it's not clear, then might prefer for more of a multidisciplinary team evaluation that Dr. Ermer was referring to before, where we've got a medical person and speech and OT or a psychologist involved in that assessment.
So it would be a lot of talking, a lot of interacting, a little bit of physical exam, looking for are there things that make us think about a genetic spectrum that might contribute to this. How's the child's hearing, and what are their skills from a fine motor, gross motor standpoint, their language skills.
Absolutely. And how well do you interact? How easy is it to get that child to engage and interact? You know, it's in a peds clinic. One of our favorite things we get to do is we get to play with kids. And so, how is this child's play skills? And are they measuring up to what we would expect for their age level? Do they have pretend play skills, or are they, focused on the wheels of the car rather than pushing the car? Those kinds of examples.
So, a lot of it might not really look like a diagnosis like you're used to. It looks like, gee, they're just playing with my child.
Yes.
And that is what we're doing, but we're assessing while we do that.
Well, one of the more specific, called the ADOS, if you don't educate the parent that, hey, it looks like we're just hanging out with the kid and having a pretend birthday party and asking about friends, but it's actually a standardized, well-studied tool. It's probably the gold standard. The ADOS is, it looks like you're hanging out with the kid playing, but you're really collecting data throughout the evaluation.
Yeah, what their skills are with that. It's interesting. We have another question from Facebook. Who can diagnose autism, and what doctor should my child be seeing?
That can be developmental pediatrician. In some places it's neurology. It can be psychiatry. It can be a psychologist. So I think there's a broad range of individuals that feel sufficient in their training to be able to make that diagnosis.
To do that. Yeah. And it is challenging because there's not a whole lot of child psychiatrists or developmental pediatricians, especially in South Dakota. So they're, I would say that start talking to your primary care doctor, your pediatrician, or your family doctor, and they can hopefully get you heading in the right direction.
I kind of want to reinforce that if there seems to be delays socially or developmental skills, I get services. Even try to get services. There's no harm that's going to come from seeing somebody intervening early on, and if they don't have autism, great, they got some services. Don't hold off until you absolutely know 100% sure.
Exactly, because even if autism is not the diagnosis, that child is not going to be harmed by getting some extra help in whatever area they've got challenges.
And you can start that with a school district evaluation. And so even if there is a wait list to get into a clinic to have that medical evaluation, you can start with that early intervention, birth to 3 evaluation, or early childhood evaluation for kids after 3 to make sure schools do a really good job of identifying communication concerns or other developmental concerns and initiating interventions that can be done while you're waiting to be seen in the clinic.
And no child's going to be hurt by that.
Right.
They're just going to be helped. ARC LLC, located in Sioux Falls, South Dakota, is a provider of applied behavioral analysis, ABA, therapy, serving individuals of all ages diagnosed with autism. The company is owned and operated by 3 board-certified behavior analysts, Addie Olson, Raina Quinnell, and Cody Haverman. They offer insights into ARC's mission and the therapy services provided there.
Olson says at ARC, they work on anything that is important to the client and their family.
So anything important to the client, it could be communication skills, it could be daily living activities, it could be we're working on social skills. So kind of just meeting the client where they're at and figuring out where there might be deficits and where the goals are and work on those.
She adds that communication is one of the most vital skills they work on in therapy.
That can look different for someone who is non-vocal verbal and might use a textbook or some other type of assisted technology to communicate versus someone who just might not know how to pick up on social cues or just say, hey, I'm really overwhelmed right now and I hear this loud noise and it's bothering me and I might need to take a break. And so that communication, just for all of us, for everybody, not just on the spectrum, is how we get our wants and needs met on a day-to-day basis. We're not mind readers, so we have to be able to tell those things to other people. And that's number one, first and foremost, the skill we teach.
ABA therapy's goal is not to continue therapy indefinitely, but you may need to see a therapist at different times of your life.
We don't want to be a forever therapy. We want to teach those skills and teach those different variables in their life where they can then succeed outside of this without us. Say you come in for early intervention services and you quote unquote graduate out of ABA services because you're at those age level of skills and development and kind of like where that client should be.
There are many aspects and working parts to the job, but Haverman says the small things are what makes it all worthwhile.
When you see these things that you're not always looking big picture, finding the small wins and then looking at these graphs, or maybe working with this client and seeing a smile on their face when they've figured out how to access something they wanted when they've never been able to do that before.
One of the things I think is so exciting is how many more opportunities there are for people with autism to get support and get that individualized instruction, help, compared to even early in my career, which was a long time ago. But it's very different now than it was, and I'm just really excited by that. So we've got a fair number of questions, so let's take a look at that. Somebody is asking, are there different levels of autism? That is a very good question. Carrie.
There are, and that was with the most recent edition of the Diagnostic and Statistic Manual. We're on number 5 now, and so they do have levels 1, 2, and 3, and they really are meant to define how much intervention an individual needs. So level 1 is needing some intervention, and level 3 is needing very substantial interventions or assistance.
Excellent. And what might life look like that's different for a person with level 1 compared to level 3?
Well, level 1, you might, unless you're aware, you might not even notice a lot of the symptoms, but they just don't need quite the structure and interventions that a level 3 person would do. I think level 3 would typically be obvious to the average person, whereas level 1 may, especially as kids with autism get older and they, a lot of kids learn social skills just kind of by naturally being in social situations, but motivated, bright kids who get the early therapies can really not look like they have a lot of autistic symptoms because they learn how to integrate with other kids and learn what they need to do, even though they sometimes will tell us they're faking it.
Yeah. So did they outgrow their autism?
No, I think they learned how to fit in kind of what the expectation is, and that's kind of individualized too.
Yeah. So bottom line, you have autism, you just may learn how to function according to expectations, even though you still have those challenges. We're not curing autism.
No.
We're not curing it.
No.
But the level of impairment may improve over time with interventions, and that's really what we're looking for, is how much is this impacting your day-to-day life? And that's really our hope, that you get these interventions early enough, or that we're continuing these interventions, that we're needing less and less support at school or support in a job situation.
Perfect. And then that's the whole point. Yep. Here's a question from email. Is autism a medical condition, a neurologic difference, or both?
Yes.
Dave.
Yes. No, we think it's a neurodevelopmental issue. There's during brain development that causes some differences. As I said earlier, there's probably multiple different pathways in the brain, and we don't understand. I mean, if someone tells you they understand completely autism, the diagnosis, and how we got from A to B, they'd be lying. We definitely know there's developmental differences and neurodevelopmental differences.
I think if anybody tells you they understand the brain perfectly, they're probably misguided.
Yes.
Yes. Caller from Mitchell, can we talk about different therapies for autism? And I think they talked a little bit about that in the roll-in, but what do you have to add to that, Carrie?
Yeah, I think really we want to make sure that we're working on communication. That's one of the hallmark diagnostic features of a child with an autism spectrum disorder. So working on communication skills, working on fine motor skills, daily living skills, adaptive skills. So that's a lot of times speech therapy, OT, helping with that. There are more intensive autism therapies like ABA, applied behavioral analysis, that really uses targeted skill goals to build skills for this individual, and it's really designed to fit that learning style that fits autism, and so those are some of the more common ones. There's many different kinds of therapies out there too, such as floor time is one. It's not a super common one, but that is another intervention where it's more relational, where it's focused much more on like getting on the child's level and playing and social skills that way too.
Helping them fine-tune that communication skill by practicing with somebody who kind of is teaching them that Correct. As they go. Are there medicines that are helpful?
There's currently no medicine that would treat the core symptoms of autism. And the majority of people with autism aren't on medicines, but there are medicines helpful if they have a comorbid diagnosis. We mentioned earlier, you see a lot of, in fact, they're kind of learning that there's some pathways that may have more ADHD, and so a lot of times we'll treat ADHD, anxiety, almost obsessive compulsive symptoms. And there's 2 medicines approved for real extreme, like aggressions or self-injurious behavior with more involved. And those are the kids who may see a developmental pediatrician or a child psychiatrist for medication management.
So there are some symptoms of autism or comorbid disorders where we have some medicines that can help. But for the most part, the treatment is those therapies.
Yeah, it is, and sometimes it's a combination of those things. It's not medicine alone. I always say it's kind of those things together. If our focus symptoms are interfering with our ability to actually benefit from our speech therapy, let's improve our focus. So then now that therapy can actually take hold, and we can learn those skills.
Perfect. Pills so you can develop skills.
Exactly. Yeah. I like that.
We have someone from Aberdeen. How are treatment plans designed for each person, and how do doctors know what to do for each kid? That's a great question.
That's a great question.
Dave?
Well, again, that's where I go back to the multidisciplinary evaluation, and each discipline comes up with strengths and weaknesses and what, like the speech therapist thinks is going to be the best approach, what the pediatrician is going to be the best approach, OT, what educational needs are there, and then you develop a plan. I don't think the physician has to design that. You really want, I'm not an educator, so I don't know how to do an educational plan, and I'm not an OT, I don't know how to do an OT plan. So you really need that team. You need to trust the members of your team to come up with a good care plan.
So I think the point is that you have that team identifying within their area of expertise what this person's strengths are, what their needs are, and helping customize that plan for them. So we had a question about OCD, and how is OCD different from autism, overlap with autism? How does that fit in?
Well, it's sometimes it's hard to differentiate, I think, because that behavioral rigidity, that kind of my way or the highway, or maybe even like routines and rituals can be one of those core diagnostic criteria for an autism spectrum disorder. And so I guess I always approach it if those symptoms are getting in the way of this individual being able to have success in their day, to function in their home or at school or in the community, do we treat that like OCD and use medications that can help treat that?
I'd agree 100%. Just so people know, OCD is obsessive compulsive disorder.
Thank you.
We're guilty of using a lot of 3-letter acronyms in medicine.
Yes, we are.
But I think you look at, is this particular issue interfering with their functioning, or is it causing difficulties? And that's where you might, the DSM doesn't specify how you got obsessions. It just says, and so I really feel like you treat same with focus. Maybe, for a child with autism, a lot of times they're not focusing because they're upset. Like I have kids with autism who are obsessed with the weather. So you sit them by a window in class, and they're not paying attention because they're watching weather patterns, and so it's a big difference, and so you really want to figure out why aren't they focusing, and maybe there's other interventions you can do too.
So there's an awful lot of art to this particular diagnosis and treatment plan. We have someone, how do you encourage a 6-year-old boy to interact comfortably? He lost his father a year ago and misses him. What can be done to nurture and support this child? The last of the question is whether he uses a tablet to watch commercials. How can we redirect this behavior? That's a tough, horrible heartbreaking situation.
I think if there's social skills opportunities or are there mentorship opportunities, I don't know if this is a 6-year-old child with an autism diagnosis or not.
I believe so, yep, an autistic child.
Yeah. That's a hard situation to explain to a child who has more expected developmental path, let alone an autism or an autism diagnosis. How do you help with that? I think making sure that we have behavioral therapy in place if that's an option, and trying to have people that understand where this child is developmentally. How do we help them understand the situation that's hard at that child's level?
I think that's where you really lean on your team to help you. And if you don't have a team, this is definitely time to get a team of people that can help with this child. And I think the caregivers are going to need some support through this too. I mean, no matter what happened, that child has had a terrible loss, and probably the whole family has had a terrible loss. So let's not forget their needs too. Mm-hmm. We have a caller from Watertown saying, my child is autistic and prone to meltdowns and more challenging behavior. What can I do? That's such a hard problem. That is, yes.
Well, if I had this question in clinic, I would say, tell me what are the triggers? What's leading to these? Can we identify? Can we go upstream and identify what those triggers are? The other thing I think about too is how are we, thinking about the whole child, how are we sleeping? Is there a sleep issue? And so we're tired. I don't know about you, but I'm not very fun to be around if I'm sleep deprived, and I might have a short fuse and be more prone to be frustrated. So are there any other reasons that we would be having these meltdowns?
And I do think that's a hard question to answer. I think it's getting a qualified therapist who knows who has some expertise in autism to really delineate those issues. What's the antecedent? What's leading to the meltdown? And what have you tried already? What makes things better? What makes things worse? So I don't think there's a easy answer. And a lot of times it takes time. Even like we talked about having a care plan, I think care plans they're dynamic. They're not static. They need to change over time. Hey, we started with this care plan. We took care of that behavior. All of a sudden, a new behavior emerged. You have to keep updating your goals and stuff,
and how you're approaching those goals. So, if that hasn't already been tried, the schedule rigidity that you had talked about earlier is such a common trigger, and that may be a place to investigate. But work with your team. Work with your team. Get a team. My child has been diagnosed with autism. Is there a certain diet they should be on? And you guys never get that question in clinic. No, never.
No, I think there's a lot out there on the internet, and I think there's a few. There's not a lot of great studies supporting dramatic benefits from diet. I certainly wouldn't argue that if you see certain things make their behavior worse, to limit those. We certainly think a well-balanced diet. I mean, the problem also becomes some kids have pretty rigid eating patterns, and so if you institute a new diet, the only foods they're eating, maybe now they're really struggling getting nutrition. So I think you do have to be careful. But they talk about a lot of different diets, and it's not robust data supporting any one given diet, I don't believe.
I would agree. I think, we get this question a lot, and we'll say, well, what diet are you thinking? And it's like, well, this is all of the foods that your child will currently eat. And so what will you feed your child? And so, really taking that approach. If as we talk about it, the family feels really certain that they want to try it, then I'll say, let's be scientific about it. Let's try it for 6 or 8 weeks. And then maybe reintroduce those foods. See if you notice a difference or not.
Yeah, and that limitations in what they will eat certainly makes it challenging, and that's true for a lot of people with autism. Absolutely. The limits and what they'll do. We've only got a couple more minutes. How do we measure progress for autism? When do you see changes, Dave?
I think that's a great question. If you're doing any intervention, you want to say, what are we targeting? What behavior are we targeting? And some of it's as simple as counting behaviors. Really that approach that we're going to intervene. What do we want to measure? What do we want to maybe improve? See less of this behavior, more of this behavior, and really measure and keep track. And some of it's going to be on the parents. They're going to feel like they're kind of bean counters, but it's really important to do that because we have a tendency to maybe remember a really extreme behavior, but maybe the rest of the days went really well compared to the early intervention was going well, but it just had that one extreme day. So I think it's real important to measure, and I know any of the therapists, like the ABA therapists, that's part of their process is measuring the behaviors, and schools do a good job doing that too, typically.
Anything to add, Carrie?
I would agree with that 100%. And I think the other thing to remember is we always want, like whether it's behaviors or a development, we really want it to be this linear graph, like this linear. But really, it's probably something that does a little swirly and curly cues all around. And so, depending on where we're at, we might have, parts where things are harder, but other things are better. And so, again, just working with your team and making sure that we're looking at the child as a whole, and making sure that overall we're moving in the right direction, or we're identifying areas that need support and we're applying more support there.
So we overall want that child, that person, to be learning the things that they need to know, need to be able to do to be successful. Yeah. This individual says their child is autistic and has sensory issues. Are there special things that I should be doing to help them? I feel like we're saying your team.
Well, I think especially OTs, kind of that's their specialties. I would really work with a professional who knows a lot about sensory integration issues, and that would be the occupational therapist.
Yeah, and sometimes the speech therapist with the dietary restrictions that a lot of people have.
Standardized measures and rating scales that they can use to identify, that the OTs can use to help really identify what are the specific areas so they can target that treatment plan for the child.
20 seconds, last thoughts.
I think lastly, I think one of the questions initially was, what progress are we making? I think we're really working hard on trying to separate out what are the different types of autism, what are their trajectories, and what might come with them. And so there was some good study this summer they've actually come with like 4 distinct subtypes. So I think we're doing a better job of breaking down this broad category of autism and really trying to individualize and personalize treatment. We're just not there yet.
Carrie, last thoughts.
And I just always say to parents, remember, this is your child. This diagnosis doesn't change that they're amazing and they're wonderful, and this is a learning style that we're going to work on. We're going to try to find interventions so that we're promoting this child to reach their fullest potential.
And that is perfect. That's what we all want. Our winner this evening is Ellen. A book will be sent to you shortly. And we'll be back after this.
My name is Dr. Tad Jacobs, and I serve on the Healing Words Foundation, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Feeling overwhelmed by the amount of health information lately? Unsure of which sources to rely on? Visit the Prairie Doc YouTube channel today to catch up on all past episodes of On Call with the Prairie Doc. And don't forget to join us most Thursdays on SDPB, YouTube, or stream our episodes live on the Prairie Doc Facebook page.
As we finish up this evening's discussion, I want to thank Dr. Kippes and Dr. Ermer for sharing their expertise with our viewers. And thank you to all of our viewers for tuning in tonight. We appreciate your continued viewership and support for our mission to provide science-based health education to everyone. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question tonight or it didn't align with our topic, send your questions to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on South Dakota Public Broadcasting Radio. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio, wherever podcasts can be found. Thank you for joining us for another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm, would say, stay healthy out there, people.
The science of weight loss encompasses a comprehensive understanding of metabolism, caloric balance, the role of physical activity, and sometimes medication. Journey to Wellness, the science of weight loss. Next time, On Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions: Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,